My name is Karen Joint-Maddox. I'm a cardiologist in the department and co-direct our Center for Advancing Health Services Policy and Economics Research. And it's my distinct pleasure to introduce my friend and colleague, Kenton Johnston, to give your grand rounds this morning. So Kenton is Canadian, which I see as a positive, and thus lovely. Did his undergrad work at University of Ottawa, and then came to the U.S. to the University of West Virginia to do some graduate work. Thereafter, he joined the dark side and worked for Blue Cross Blue Shield of Tennessee for a while. And then when he left there, it was Blue Cross's loss, I'm sure, but our gain, because he took all that he'd learned in working in private sector and with claims data off to get his PhD at Emory University, which is one of the top health services research programs in the country, where he trained in the kind of work that he'll talk to you about today, really using very sort of high-end analytic methods to be able to explore big data to try to understand some of the most vexing problems in health policy. So following his PhD at Emory, he joined the faculty at SLU, and we were lucky enough to recruit him away from SLU a few years ago for him to join general medicine here, now the General Medicine and Geriatrics division, where he's been phenomenally productive in terms of research and grants, but also just a wonderful addition to the WashU community in helping us build out research infrastructure as our Associate Director of Research for the center, mentoring, growing his team, and really bringing, I think, important perspective on health policy to this institution. I'll make two quick asides. The first is that for anyone having health policy-related anxiety related to the election, we were just discussing with Vicki that perhaps we'll do something as a center to try to think through what are some of the health policy things we might expect going forward. I think we've done a lot of thinking about what it could look like, but it'll all get a lot more real in the next few months, and so we'll try to find some forum to come back and talk about that collectively. I'll also put in a quick plug for next week's Grand Rounds, where Kevin Volpe will be here, also co-sponsored by our center. He's a behavioral economist and a leader in the food as medicine space, and so come join us all for that next week as well. So with that, I will turn it over to Kenton. Thanks.
Well, thank you all for having me here today. I'm excited to do this talk. I think I've found that this is my first time working in a medical school, and so I found that people are really interested in how physicians get paid, which makes sense. We're all interested in how we get paid. And so I'm going to talk to you today a little bit about Medicare value-based payment models, what those are, and how physicians have been participating in those over the last 5 to 8 years. These are my standard disclosures. I also really want to acknowledge co-investigators Karen Joint-Maddox, Alex Everhard, who's an instructor in general medicine, and Peter Liu and Jason Hockenberry at RTI International in Yale. I also want to acknowledge my lab team that's here, Mega DeBoss and Michelle Hendricks and Brandon Tabman, and thank them for their hard work. And also thanks to the funder. Just a side note on healthcare funding, it's always good to diversify. The NIH is great, but it's always good to diversify your funding in research and life. Anyway, let's get on to the agenda here. So this is kind of broken up into three parts. We'll talk a little bit about the big picture on Medicare, and I want to allow like a break because, you know, Medicare is, the details on Medicare may not be familiar to all of you, so I want to, at the end of each section, give you a chance to ask some questions. Then we'll talk about what value-based payment models are for physicians in Medicare. And then lastly, I'll share some research that's under review right now on physician participation in Medicare's value-based payment models over time. And so talking about the big picture in Medicare. So Medicare is a program that was passed back in 1965 along with Medicaid, and it ensures people who are ages 65 and up, as well as people with disability entitlement through Social Security disability entitlement, and people with end-stage renal disease. And so it's one of the largest and most important health insurance programs in the country. And really, when it was first passed, it was divided into two parts. Part A is the part that people are automatically enrolled in once they become eligible. And that's really your hospital and facility type services. So it will pay for hospital visits, skilled nursing, emergency department visits, home health. And that's paid for via payroll taxes. We all have a line item on our payroll taxes for that Part B is a voluntary part of Medicare, but the vast majority of beneficiaries will sign up for this, and this pays for physician and professional services and durable medical equipment, and that's Part B is what I'm really focused on today, and it's paid for by general taxes and a monthly premium by beneficiaries. Together, these two components form what's often called the traditional Medicare program, because this is how Medicare was originally passed. And then a growing component of Medicare that I'll talk a little bit about is Medicare Part C. It's been called Medicare Choice or Medicare, it's now called Medicare Advantage. And this really started in the 90s and has grown a lot since then. This is essentially getting your Medicare Part A and Part B through a private insurance or managed care plan. And so Dr. Joy Maddox mentioned that I used to work for Blue Cross Blue Shield of Tennessee. They provide one of these or multiple of these plans, Anthem, United Healthcare. It's like getting your Medicare through one of these health insurers. And then Medicare Part D, that's the voluntary prescription drug program that was passed in 2003 under the Bush administration and then expanded under the Obama administration. And this again is a voluntary program for prescription drug coverage, but definitely the vast majority of beneficiaries also sign up for that. And so when it comes to the big picture for Medicare, one of the most important things to know is that enrollment in Medicare is growing fast. And we're kind of in the steepest part of the curve right now as the baby boomers are aging into Medicare. And so today it's a little over 63 million beneficiaries, and that's projected to grow to something like 75 million by 2030. And so the program is really growing fast right now in terms of total enrollment. And you think about the people who enroll in Medicare, generally when you enroll in Medicare, that's at the point in your life when you need the most healthcare services. And so concurrent with that, and not surprisingly, Medicare spending, expenditures by the federal government are also growing fast. And these are projected to double in the next 10 years, whether it's the trustees of the program who are projecting this or the Congressional Budget Office. The thing to know, the other thing I would add about that is Medicare spending is it's not only growing because of this growth in enrollment of people aging into Medicare. It's also growing because of inflation, like other parts of price inflation, like other parts of consumer goods and the economy. But the thing to know about healthcare inflation is it's generally a lot more than consumer price inflation. It's often double. So the expenditure growth is it's a double whammy, both because more people are enrolling in Medicare, but also because the average unit price per service is growing and faster than the rest of the economy. And so the question is, so what? Why is this an issue? Is it an issue? And so I wanted to share these two graphics. A lot of this comes from recent analysis from the Medicare Payment Advisory Commission. And so the graph on your left-hand side here shows how Medicare is funded. And I mentioned earlier that it's funded by a combination of payroll taxes, that's the bottom shaded area in dark blue, premiums, which is the bright orange shaded area, but also general revenue transfers, so just general taxes. And you can see that's, as the expenditures grow, that's the area that's growing the most. So more and more are coming not just from the line item on our payroll or from beneficiaries' premiums, but just from general revenues, which is taxes for everybody. And so the question is, well, so what? Why is that an issue? Well, if you look at the graph on the right-hand side, that's comparing the growth in Medicare beneficiaries in millions over time, which is, we're right now in a very steep part of the curve. The graph on the right-hand side is looking at change in the number of workers in our economy, so people paying taxes per insured Medicare beneficiary. And you can see that that's decreasing pretty steeply over time from over 4.5 workers per beneficiary to now we're down less than 3, and it's going to continue to decline. This is a problem right now in like all advanced economies. In the US, it may be more acute for Medicare just because due to healthcare inflation increasing more here than in other countries. And so this is why you'll often hear people say, oh, the healthcare spending trajectory is not sustainable. And people kind of roll their eyes when people say that because they've been saying it since the 1980s and we're still here and we still have Medicare. But this is what economists are talking about, is this particular trajectory when there are fewer people paying taxes to support a larger number of beneficiaries, and the cost of the program is growing a lot. There are other two big trends that I've kind of alluded to. Well, one of them I've already alluded to, and this is really the most important trend in Medicare right now, and so this is the growth in Medicare Advantage. So receiving your Medicare services rather direct, instead of receiving the health insurance directly from the federal government, more and more people are opting to receive it from private managed care insurance companies. And last year was actually the tipping point where more than 50% of beneficiaries began receiving their Medicare through Medicare Advantage. And this year it's at about 53, 54%. The Congressional Budget Office projects it to grow to 64%. To be honest, I think that's a conservative low-end projection. It may actually end up being more than that based on how steep the trend has been in recent years. The thing that I think is interesting here is as Medicare has grown, as more and more people have enrolled in it, the traditional Medicare program actually hasn't grown. If anything, in terms of total raw enrollment, it's shrunk a little bit. And so you can sort of think of it as like all the new volume of people enrolling in Medicare, all that volume has gone over to Medicare Advantage. The other important trend in Medicare has to do with the traditional Medicare program, what's sometimes called the fee-for-service program, and we'll talk about that a little more in a minute here. But the important trend here is the growth in accountable care relationships or accountable care organizations, which is the most important value-based payment model in the traditional Medicare program. And so at this point in time, more than 50% of traditional Medicare beneficiaries are now in accountable care organizations. And as I'll talk a little bit more in a minute, one way to think of ACOs is that this is a way of CMS and the federal government shifting some insurance risk from themselves onto these entities called ACOs. And economists refer to that, and people in insurance, as risk-based payment. Now, Medicare Advantage is already a form of risk-based payment because insurers are they're getting paid by the federal government to take on the risk of beneficiaries. To a certain extent, ACOs are as well. And so together with these two trends, we can think about the fact that about 4 in 5 or 80% Medicare beneficiaries are now under some form of risk-based payment. So no longer just direct fee-for-service, whether it's through a Medicare Advantage plan or an ACO. And that's kind of like a really big 30,000-foot view of the Medicare program today. But before I move on to talking about physician value-based payment models, I thought I'd stop and see if anyone has any questions, like big picture questions about the Medicare program. Yeah.
So on Medicare Advantage and ACO, so what benefit is it to the patient to enroll into those, and what benefit is it to the system to have it other than risk?
Yeah, like why are more and more patients enrolling in it?
Can you repeat the question so that
Sure.
when it's recorded, they know what the question was?
Yeah, the question is, so there's been a lot of growth in Medicare Advantage, so what benefit is it to patients to be in Medicare Advantage? And then that's the second part, I think, is, well, what's the impact on the healthcare system? I think the value to patients or consumers is pretty transparent and clear when you look at the financials. Patients often do not have to pay any premium at all for Part B. And so remember, we talked about how Part B is funded by premiums. Because Medicare Advantage plans, on average, get paid a little bit more and are able to save some money through utilization management or through using networks. The idea behind a network is some doctors and hospitals are in network, some doctors and hospitals aren't. The fee-for-service program has to take everybody in the network, whereas Medicare Advantage, like Humana, could decide we're going to include BJC but not Mercy in our network. And so by creating savings that way, Medicare Advantage plans are able to reduce premiums. And so beneficiaries often have zero premiums to enroll in a plan that bundles all of Part A, all of Part B, and often all of Part C together. In addition, Medicare Advantage plans will offer benefits like transportation benefits, wellness benefits, dental, vision, hearing benefits. And so it's a way, I think the short answer is it's cheaper for the consumer to enroll in Medicare Advantage. It's not cheaper for the taxpayer or for the federal government, but it's definitely cheaper for the consumer on average in terms of premiums and copays and deductibles and things like that. The second part, is it good for the system? So there's a huge debate in health economics and policy right now. I think the consensus view is that it is not, it's actually more expensive for taxpayers. And so whether that's good or bad is kind of, it depends on your perspective of, well, are patients getting enough reduction in their cost sharing to make it worthwhile? But the reason for the growth in the number of consumers enrolling is from a financial perspective, it makes sense. It makes sense for them. And we're seeing more lower income people enrolling in Medicare Advantage because a lot of, if you don't have purchased private supplemental insurance for traditional Medicare, there are actually a lot of deductibles and copays that you have to pay. And so it tends to be wealthier people or people whose employers have provided that in retirement that have private supplemental insurance to kind of fill in the gaps in the traditional Medicare program. And people who don't have that Medicare Advantage because of cost savings due to what most people think is overpayment and then also able to reduce costs through utilization management, it has to share some of that with consumers, and that attracts more consumers into the market. Any other questions? Yeah.
But then what about the downsides of enrolling in Medicare Advantage?
Yeah, so there are some downsides. So the downside to Medicare Advantage are probably the downsides that all of us experience who are in private managed care insurance plans, which are they're going to engage in utilization management, which means some services end up getting denied, and so that can be very frustrating for people. Probably a lot of us have experienced that. The other downside of being in Medicare Advantage is this would be the most important thing I would focus on for people like friends and family members trying to decide what do they want to be in, is not all doctors and hospitals are in network. And if your doctors and hospitals are not in network, then you're going to pay a lot more money. And so people really need to do their research and make sure, are my doctors and my healthcare providers in network before I sign up in this insurance plan? And not everyone does that research. And so that would be a big downside. From a health system perspective, it's probably, well, in the past it used to be easier to deal with traditional Medicare because it was just fee for service and you didn't have to deal with a managed care company. As we move to value-based payment, that's a little less true. It's becoming, I would say, more of a hassle to deal with the traditional Medicare program because you have to submit all kinds of quality measures, and it's becoming a little bit more like managed care. But yeah, that's a great point. Any other questions? Yeah.
Could you comment on Medicare Part B and whether there's still a penalty for not signing up if you do traditional Medicare? And then I have a second question. Is Medicare Part B rolled into the Advantage plans always, or is some have it and some don't?
It is almost always rolled into the Advantage plans. In terms of a, yeah, the question has to do with Medicare Part D and if there's a penalty for not enrolling if you're in traditional Medicare. Part D isn't really like my number one area of expertise, but I'm not aware of there currently being a penalty for not enrolling in Part D if you're in traditional. There is?
If you don't enroll when you're eligible, there's a penalty that increases the longer you put it off. But if you have comparable drug coverage to your employer, you can still enroll for Medicare and you don't have to sign up for D.
Oh, great. Thanks for that. Yeah,
It's
it's
a penalty.
so
It's a lifelong penalty.
interesting.
Yeah, I know it used to accrue. The longer you wait,
Still does.
Yeah.
the more expensive it is. And that was my question, is that still in play? And has the government looked at this? Because it is a barrier for patients.
Sure.
So I thought that landscape might be changing.
Yeah, interesting. I mean, there's also a similar incentive in Part B as well. This is why the vast majority of people sign up in Part B. When it comes to this, the second part of your question has to do with Medicare Advantage. And so that the vast majority of Medicare Advantage plans have Part D services bundled together. Yes?
Can you comment on the physician role in this model and how that's contributing to the excessive costs?
Yeah, so that is a great segue as well into the physician value-based payment model. So physicians, or the practices or health systems they belong to, contract with Medicare Advantage plans. And part of that contracting is there's a negotiation process between the health system or the practice and the plan on payment rates. So what are the payment rates going to be? Whereas the fee-for-service program, you just take whatever the rates are, and anyone willing to take those rates serves Medicare patients. And so managed care plans, as part of that contracting process, they have to think about, well, we want to get as many people to sign up, consumers, as possible, so we want to make sure we take the hospitals and doctors that our consumers want, but on the other hand, they're also thinking about, well, maybe we shouldn't contract with this particular group, this hospital or physician group, because they're going to bring a lot of high-risk patients that are not paid for by Medicare in a way that's financially advantaged or might cause us to lose a lot of money. So you can think of it more like Medicare Advantage. You can really think about it like the private health insurance system, like the relationship between physicians and in this case, the health insurer would be a lot more similar to private insurance than it would be the fee-for-service program.
I guess I was kind of more thinking, I apologize, I didn't say it initially, the shared risk model.
Oh, yeah.
And how that affects physician behavior and thereby affecting costs.
So this is a perfect segue to, I'm going to talk about that in this section, the physician value-based payment models in Medicare. And shared risk is a really important part of this. And so to kind of frame that question, let's talk about, well, what is value-based payment and how does it compare to fee-for-service payment, which is the kind of payment that used to exist in Medicare, and that still really, in a large part, does exist. And so, as I mentioned earlier, Part B is the physician and professional services component of Medicare, and really since the 1990s, policymakers have been talking about reforming fee-for-service. The idea is, the basic idea of fee-for-service is the more services you do, the more you get paid, because it's a unit price per service. And I'll talk a little bit more about that on the next slide. And so last decade, under, I think it was late in the Obama administration, CMS set a goal of moving all Part B services to some kind of value-based payment by 2020. And I'll talk in a minute here about the range of the different types of value-based payment. In this decade, CMS has set a goal of moving all Part B beneficiaries to accountable care relationships by 2030. And both of these things have started to happen, but they haven't, the goal in terms of 100% of services under value-based payment, that's a little debatable of whether that's actually happened. The important thing to know is the umbrella payment model for paying physicians in Part B is called the Quality Payment Program. So you can already tell, like, that's not a fee-for-service, a 100% purely fee-for-service structure, just the fact that they have quality baked into that. And I'll talk a little bit more about that in a moment, but that's the big umbrella payment program that all these value-based payment programs exist under. And this was implemented in 2017 to replace a prior fee-for-service payment system called the Sustainable Growth Rate. There was a special formula they had for that, and it was authorized by Congress in 2015. And this was very bipartisan legislation back in 2015, so this is not something that I see going away anytime soon. This slide is kind of a lot, but it's the top part of the graphic is really illustrating what the fee-for-service system looks like. And basically, each service, you've probably heard of relative value units or resource-based relative value units. Each service is graded by like a special committee that decides, okay, this particular service provided by this particular specialty is worth X amount of dollars. And then there are all these like geographic adjustments, practice adjustments, other kind of adjustments. But the basic takeaway here is that you end up with a fee per unit billed, and that's going to stay the same. The reason that people criticize that is that it really incentivized billing for as many units as possible, because the more units you bill for, the more money you get. And so probably everyone in their career has been encouraged by practice managers to bill in a certain way. And this is the reason for that. The idea behind a value-based structure is that, well, we're not just going to pay for units billed, we're going to pay for the actual value of the services. But of course, deciding what the value of services are, the devil is in those details. And so the way this is actually implemented in Medicare, the value-based payment structure can range from like a minor up or down adjustment. You can think of as a performance-based payment, like, at the end of the year, the insurer, in this case, the Part B program, will rate physician practices on a number of quality metrics. And if you work for BJC, the health system has a lot of good people who are going to take care of making sure that the best quality measures are reported. And so if you did good, you'll get an upward adjustment on your fee-for-service payment structure. If you didn't do so well, you'll get a downward adjustment. That's called the merit-based incentive payment system. I mean, it's kind of like the default payment system in Part B, or the quality payment program. And then this value-based payment structure ranges all the way to full risk-based capitation, which means the physician practice is actually acting almost like an insurance company, taking on risk for the patients they care for. And in between that, there's a lot of different payment models. And so this slide is kind of, I'm not going to go into each and every one of these payment models. There are now over 30 different payment program schemes in Medicare Part B, and they really do range from this very like minimal value-based structure that I mentioned with up or down adjustments, which you can tell that's really just the fee-for-service architecture, adding some performance-based payments on top. And they range all the way from that to different degrees of sharing risk with CMS for patients' cost of care, while also monitoring patient quality of care. And when it comes to ACOs, the degree of risk really varies. And so each patient, just like they are in the Medicare Advantage program, there's a risk model where each patient is predicted to cost a certain amount in the next year. And if they cost more than that, then if you're in an ACO that shares a lot of risk with CMS, meaning you share risk for both losses and savings, you have to share the losses with CMS. If you're in other types of ACO models, if you're in a one-sided ACO model, you just share savings. A two-sided model, you're sharing both savings and losses. You can think of it as like risk on a sliding scale, from very minimal risk in some ACOs that are called one-sided ACOs to increasing levels of risk in two-sided ACOs. And if you go to the far right on the scale, it's just like the ACO is a managed care insurance company sharing full risk with CMS. When it comes to thinking about these payment models, one of the things that my co-authors and I have done in this study is we've taken all these payment models and we've grouped them into these categories on this continuum of participation in value-based payment. And so no participation on the far left side would be really, you're not participating in any kind of measurement or performance-based payment for your quality of care, and definitely no risk sharing. And so a lot of clinicians fall into this bucket just because they don't meet a certain threshold which is 200 Part B Medicare patients in a year, and so they don't have to participate. And as we'll see, that's a growing number of clinicians. Then there are these value-based payment models that are kind of like I would say, value-based payment model in name only. Really, they're on the traditional fee-for-service architecture, like the merit-based incentive payment system that just adds minimal up or down adjustments to your fee-for-service payments based on quality measured over the past year. And often that quality is not measured for the individual physician. It's usually measured for the whole practice that you're part of. And if you're part of a practice in a health system, they're going to know they're going to have the management, administrative, and information architecture to be able to figure out what the best well, the other thing is you can pick your own quality measures that you submit to CMS. So if you're part of a large system that knows how to work that, they're going to submit quality measures that are going to be in your advantage. If you're a one-sided ACO participant, as I mentioned, this is sharing savings but not losses with Medicare. So all your patients are projected to cost a certain amount in the next year, and say, on average, your patients cost less than that. Then you would share in the savings with CMS. Two-sided risk ACO means you share in both the losses and savings. When it comes to two-sided risk ACOs, I think the important thing to know is that this is really the end goal of the traditional Medicare program. And so the goal is to have all traditional Medicare beneficiaries enrolled in some form of accountable care by the end of this decade. And so you can think of ACOs as like, this is the go-to cost containment and quality improvement strategy in traditional Medicare. And the ultimate goal is shifting more financial risk for ensuring and caring for beneficiaries from CMS, from the federal government, to the ACO entity. And ACOs, you can think of ACOs as large contractual entities. Often they're health systems, sometimes they're hospitals or multi-group practices, and they will typically, so BJC has a Medicare shared savings ACO, and that ACO then contracts with physician practices and hospitals, and together they decide we're going to be at risk for a set group of beneficiaries, which is sometimes determined prospectively, so you know in advance. Other times it's determined retrospectively based on which patients you had the most contact with over the past year. The largest ACO program in Medicare is the Medicare Shared Savings Program. It's been in place since 2012. There have been a number of other different iterations of ACO programs, and the current second largest program is the ACO REACH model. And so this started in 2023, and the focus of ACO REACH is really on increasing autonomy and flexibility for ACOs, almost like their Medicare Advantage plans and the kind of services they cover. And they're also taking on a lot more risk than the typical ACO and the shared savings program. Part of the idea is that they're also being paid based on not just medical risk, but social risk. And so there are specific not only quality benchmarks, but equity benchmarks, and where the payments are adjusted for taking on patients with more social risk factors. The idea is that this gives ACOs more freedom to address things like social determinants of health in addition to other medical issues. Okay, so that is, the payment model landscape in Medicare is very complex. This is like, kind of just dipping a toe into the water. Before I go into the third part, which is who's actually participating in these models, I thought I'd check to see if there's any big picture questions on Medicare payment models, particularly ACOs. Yeah.
So those ACOs are in traditional fee-for-service, so they can go across systems. So how does that work? Because you're endocrinologist could be a SLU, WashU could be your oncologist. Like, how does that work for an ACO?
Yeah, this is a big disadvantage that ACOs face versus Medicare Advantage plans, right? Like, they don't have networks where patients, have to pay out-of-network costs to go to other providers. However, if, let's say this is BJC acting as an ACO, the physicians can refer the primary care physician can refer the patient to, let's say, specialists or other providers that are within the ACO network. And usually patients often will follow up on those referrals. But you're right that they don't have the same, they have some tools to send patients to other parts of the ACOs, but they can't, those tools don't have as much teeth as in a managed care plan. Any other questions? All right, so let's talk about who's actually participating in these value-based models. And so again, we're focused on the Medicare Part B program, the traditional Medicare program. And so for this study, we looked at all 100% Medicare data for all Medicare physicians participating in Part B in the traditional Medicare program. The only physicians we excluded were radiologists, pathologists, and surgeons. And so this is about 7.5 million clinician years of data. And we're tracking payment model participation in the categories, the large buckets that I showed you earlier over the years 2017 through 2022. The first thing, and so this is really all primary care and medical specialist physicians. The first thing to notice in this graph is the large gray area at the top. These are all the clinicians in Medicare that are not participating in any value-based payment model. They're called, in the quality payment program, they're called QPP exempt. They're exempt from the program because they don't see at least 200 Medicare patients in a year. There are some other criteria around services and dollars as well, but it's largely the patient threshold that keeps them from participating. And that has actually grown over time. And so that grew from about a third of clinicians in 2017 to almost 42% in 2022. And so you can think of this as not really being congruent with CMS's objective of engaging more clinicians in value-based payment models. The payment model program that most people have heard of, the MIPS program, which is this up or down adjustment based on your fee-for-service payment, that participation in that has declined from 43% in 2017 to about a quarter in 2022. Over the same time period, participation in two-sided ACOs increased. So that's the dark shaded area at the bottom. And this is really what CMS's goal is to get as many clinicians participating in there as possible. So you can see it has increased a lot from 6.8% to 21%. So that would be something CMS thinks is a good thing. However, it's still pretty low if you think the goal is, well, we need 100% of beneficiaries to be in ACOs. We probably need more than 20% of clinicians delivering services to be part of these two-sided ACOs. The participation in one-sided ACOs has decreased a little bit. That's by design, because if an ACO is in the shared savings program is one-sided, so meaning it only shares in savings and not losses, over time, CMS puts them on something called a glide rail, which means they either have to switch to two-sided risk or stop being an ACO. And so that's why we see that, that category shrinking over time. Another way to think about this is, well, if there's been change over time, we see the change in the trends, where have physicians who became QPP exempt, who stopped participating in any payment model, where did they come from earlier? What part of the Medicare program, what payment model were they in earlier? And so the very top bar shows all the clinicians in the data who were QPP exempt, not participating in any value-based payment model in 2022. And you can see that 72% of those were not participating in any value-based payment model in 2017 or whatever the first year was that they entered our data set. So they just were stable all along, not participating in any value-based model. Ideally, like CMS would like to see this shrinking over time, but it's growing. And so what that means is that there are clinicians who, when we first looked at them in 2017 or whatever year they first showed up in our data, they were participating in another value-based payment program. Most of them in MIPS or one-sided ACOs, and then at a certain point in time, they stopped participating in that program and became QPP exempt. The other part of this graph that CMS policymakers would really be paying attention to is two-sided ACOs, because we saw that those are growing. And so what that means is when clinicians first started in 2017, they were participating in other value-based payment models or no value-based payment models. Most of them, in this case, came from the traditional MIPS program or from one-sided ACOs. Only about a third of those in two-sided ACOs in 2022 had participated in two-sided ACOs all along. So that, really the bottom part of this is the success story. The top part of this is not a success story. The payment models in the middle, the traditional MIPS program, there's been some movement from other areas, but again, 2/3 of people participated in that the whole time. And then one-sided ACOs, there's been some movement. And then the last category here are all the other alternative payment models, which there are a lot of them, but very few clinicians actually participate in those. The other way we looked at this data was we looked at this by primary care versus specialists. And so so primary care physicians, PCPs are on the top, specialists are on the bottom. The general direction of the trends is qualitatively similar. However, the thing that we found is that specialists were a lot more likely to not participate in any value-based payment model, to be in the QPP exempt category at all points in time. But you can see that's growing in addition to PCPs, and a lot more specialists are not participating in any value-based model. And specialists were also less likely to participate in two-sided ACOs, a lot less likely. However, so that's a negative from CMS's perspective. However, the positive here is the dark blue bar at the bottom, where both primary care and specialist participation is growing. It's still low, especially for when you look at all specialists, it's still low, but it is growing over time. The rate of growth was faster among primary care physicians than specialists. And the other thing to know that's not shown on this slide is we looked at the patient volume data behind, so who are the patients that these different clinicians are caring for, and these increasing rates of QPP exemption, not participating in any payment model, they coincide with declines in patient volume, services rendered, and allowed charges for services from the physicians who are becoming QPP exempt. We also, in a more recent analysis, we are starting to zoom in on particular types of specialists. And so a big thing to keep in mind for the Medicare program is that this program is insuring people, the majority of whom are 65 and up, so at a stage in life when a lot of people have complex chronic conditions, and that's what drives a lot of the costs in Medicare. And so you can think of things like diabetes and heart failure. And one of the goals really a big goal of managed care, but also of accountable care policy, is to both improve population health outcomes, so they're really focused on population health while constraining costs for patients with these chronic conditions. You can ask if those two parts of those goals are really congruent with each other, constraining costs while improving quality and outcomes. But that's really the big picture goal of accountable care policy. And so what we wanted to look at were specialists that are important for particular key chronic diseases to see if they're engaging in two-sided ACOs versus other payment models. Because remember, we found that specialists in general are less likely to participate in two-sided ACOs. But when we looked at specific specialties like cardiology, endocrinology, nephrology, oncology, and pulmonology, you can see that these specialists are actually more likely to participate in two-sided ACOs, far more likely than other specialists, and in a few cases even more likely than primary care physicians. But in general, these types of specialists, their participation in payment models is more similar to PCPs than it is to other specialists. And part of this is because more of these types of specialists have been shifting into two-sided ACOs over time. So that's what's shown in the the dark blue on the far left, and then part of that, the volume in coming into two-sided ACOs, people are leaving traditional MIPS. And so that's really a positive story for CMS, the growth in two-sided ACOs among PCPs and these particular chronic disease specialties. On the other hand, there's also been growth among all specialist types. In the light gray on the far right there, this is more people not participating in any payment model over time. So there's both a positive story in the data and a negative story in the data from the perspective of CMS. I think the big picture takeaways of this study are that there has been growth in two-sided ACO participation. However, if we look at where we're at today, or at least in 2022, the latest data that we had available on this, the proportion of clinicians who didn't participate in any ACO or value-based model also grew. And so that's concerning when you think about, well, how is CMS going to engage all beneficiaries in accountable care relationships if their clinicians are not participating in any value-based model? In addition, although two-sided ACO participation has grown, it's still pretty low. And so, again, that's ultimately where CMS is wanting beneficiaries to go, and so it seems like they would need to engage more clinicians in those models for that to happen. Specialists were more likely to be QPP exempt, and so one of the criticisms of a lot of these models is that they're not really designed around specialists, although I think the exception to that is that we saw that for these key chronic disease specialists, they are more likely to participate in two-sided ACOs. My hunch is because those specialists are often acting almost in the role of primary care physicians, like they're the physician who, say, a patient with heart failure is seeing most often, or a patient with cancer is seeing most often. The takeaway, I think, big picture for CMS is that some strategic changes are likely needed in the design of these models in order to get more clinicians engaged in them. And there are, I think, big picture population trends as to why more clinicians are not participating in the models over time, are QPP exempt. So I mentioned earlier that Medicare Advantage penetration or market take-up is growing. And because Medicare Advantage is not included in these value-based payment programs, if you're a physician practice and like 75% of the Medicare beneficiaries in your market, which is the case in some counties, are in Medicare Advantage and not in the traditional Medicare program, then you may not even have the patient volume. You might not have 200 traditional Medicare patients anymore. Or if you do, you may not have enough volume to justify all the hassle and rigmarole of dealing with like a two-sided ACO, and so you would just do the bare minimum. And so the takeaway here is that CMS really needs to think more about how can we engage clinicians across all of Medicare in value-based payment. We wrote a blog, policy blog on this. Our basic takeaway here is that there's been a lot of growth in the number of, remember the slide I showed earlier about all the payment model schemes in Medicare? There's been a huge amount of growth in that. And so you can think of the fixed administration costs to CMS of administering all those payment models. And a lot of them, very few physicians are participating in. And so you have to hire people to run the payment models. You have to hire, many consultants to analyze the data and tell you how well the payment models are doing. And that really, I think, blunts some of the effectiveness of CMS's big picture goals of getting everyone engaged in accountable care relationships. And so our basic argument here was that CMS should do fewer things better, basically, would be the takeaway, and really focus on engaging people in the ACO-type whole person population-based care models. All right. With that, this is your summary slide of what we discussed and next steps. If you want to read the Health Affairs blog post, the link is there. I also think that this is something you need to get points. So kind of like MIPS or payment model. Anyway, I want to open it up for questions. We got about 5 minutes left, and thanks a lot for your time.
Kenton, thanks so much for that
Yeah.
talk. That was really helpful. I think you made a very complicated topic understandable for all of us because it impacts everybody. We do have time for a few questions. Does anybody have a question? Peter?
With the increase in the exempt providers, how much of that do you think is incidental versus intentional? As in, you mentioned with the rise of Medicare Advantage, that it might just be that people incidentally fall underneath the 200 patient threshold, versus are you seeing more practices saying, this is too much of a hassle, I am actually just going to deliberately not take care of that patient population group?
I think it's a mix of both. This is something we need to delve into more in the research. So the incidental argument is that, yeah, just volume of traditional Medicare patients is declining because the number of those patients in your local practice area is declining. That would be the argument for incidental. The argument for intentional would be the way CMS actually measures clinicians is your unique combination of you as a clinician with the practice that you're part of. And so there may be some gaming in terms of, well, I've seen, this would take a lot of like having access to the data, but I've seen this many patients under this TIN, maybe I'll bill the rest under this other TIN. That way I don't hit 200 on either one. I will say when we looked at all this also at the end, what's called the tax ID and physician NPI level, we didn't really see much difference there. My guess is it's mostly incidental. There may be a little bit of gaming. I will say that if you meet some of the volume thresholds for MIPS, but not all of them, so there's not just 200 patients, you have to have at least 200 services, $90,000 in allowed charges in a given period. If you meet like one or two of those, you can voluntarily participate in MIPS, and maybe in earlier years more people were doing that, and now fewer are. Yeah, that's a good question.
So
That's
Kenton,
important.
what do you think Medicare is going to do to force people into what they want them to do to ultimately try to control costs?
Yeah, will they force them into that? The argument for doing that is that they need to control costs. The argument for not doing that is that they don't want to. There are some specialties where there's already low Medicare participation rates. So I'm thinking of psychiatry right now, and so they don't want to make people angry and make it more of a hassle to deal with Medicare. I think it's really up in the air as to whether they are going to add more. Like there's carrots and sticks right now. Are they going to add more sticks? I don't want to. Yeah, I have no idea. Is the honest answer to that question.
I'll ask the slightly flinter question, which is to say, a lot of these outpatient practices are being taken over by private equity.
Yeah.
Do we have any idea of what that's doing?
Yeah. So if private equity takes over a practice, I'm an economist, so its goal is to maximize profits while not going out of business or running afoul of the government. If it thinks that it can profitably run a two-sided ACO, which was under the prior iteration of ACO REACH, was a program that private equity was somewhat interested in, then it may take on two-sided risk, right? On the other hand, it might decide that it doesn't want to deal with all of this or that it's going to cause them to lose money, and so they would probably, if they had to participate, choose traditional MIPS and do what a lot of health systems do, which is just report the quality measures that everyone performs on best, get the maximum bonus, and yeah. The goals might be a little more just like utilitarian around profit maximization, I would guess. Yeah.
Along those same lines and gaming the system, as a specialist, I've worked alongside of internists and primary care doctors who've really all they really cared about was Medicare Advantage, this two-sided model, and maximizing this chunk of money. And what happens is these doctors just start listing every single diagnosis that has ever happened in their documentation so that they increase the risk score, right? So they're gaming the system, they check all the boxes, diabetic foot exam, et cetera, and it seems that A, it would drive up costs a little bit,
Yeah.
and B, it doesn't distribute care, I guess, as specialists. We don't get to see patients that sometimes we would otherwise because of that group trying to keep all the money within themselves.
Yeah, so if they put like a heart failure diagnosis on a patient, they're going to get paid a lot more. If they like throw on a depression or dementia diagnosis, it's not going to matter as much. And so, yeah, there's like this whole, based on the diagnoses, payments are attached to that. The other part I'd add to this is if you have a private equity company, you have a lot of expertise in taking on risk, and that being a successful strategy for you, then you might end up doing what like the health system in Pittsburgh, UPMC, did like, gosh, this is like over 10 years ago now, which is they said, hey, we can just compete with, I think it's High Point or Highmark out there, Blue Cross Blue Shield, and so they developed their own insurance company. And so you can also think of consolidation, and then the insurance company went out and bought Allegheny Health Systems so that they could compete with UPMC on that. So I think consolidation is going to be, it is a trend in all of this, and it's going to continue to be. And little advertisement here. We have a health data boot camp in April where we share a lot of the healthcare data sets that our center has, and we're bringing in a special speaker. We're going to talk about consolidation and corporatization in Medicare. And so look out for that. You're all welcome to attend.
Kenton, thanks so much.
Really appreciate it.